Okay, so a dislocation. So, I mean, potentially you could dislocate any joint in your body, right? You could dislocate a finger joint, you could dislocate your wrist, but let's look at the most common one, and that's going to be the shoulder joint. So the glenohumeral joint. And why does this one dislocate so easily? Well, it's a pretty unstable joint to begin with. So the shoulder joint gives you lots of mobility, meaning you can move your arm in almost any direction you want. You can put it over your head, you can put your arm behind your back. So with all that tremendous movement, it comes at a cost. And the cost is it's not as stable. Okay? So um, when someone dislocates their shoulder joint, it needs to be put back into place, right? And typically we try to put it back into place as soon as they come into the hospital. Because if we leave it out longer and longer and longer, well, the head of the humerus belongs in the what's called the glenohumeral fossa. It's a ball and socket joint. And if we leave it out, it's not going to get proper blood supply, and it could lead to avascular necrosis. Okay? So, and also, the longer we leave it out, the harder it is to put it back in because all the muscles spasm around the dislocation. Okay? So, typically, this is a painful procedure. Not always. Sometimes we can do it without sedation and analgesia, depending on the patient and depending on how comfortable or how uncomfortable they are. Uh, but often we need sedation and opioid analgesics to get the joint back into, to get the dislocated bone back into the joint. Okay, and there's different maneuvers that we use to put the dislocation back into the joint. Okay, and you can imagine all the ligaments that have been stretched, ligaments and tendons that have been stretched as the head of the humerus has come out of joint and stretched all these ligaments and tendons. So it's not just about putting the joint, the bone back into the proper joint, um, but they're going to likely require some physiotherapy later because of the ligamentous and the tendon injury. Okay. Okay, so continuing on with dislocations, another joint that can be dislocated but with much more force, typically in the setting of a car accident, because the hip joint is so incredibly strong, it's very hard to dislocate the hip joint. But if you look at the image on the right, look where the blood supply comes in to the femoral head. Okay, so it comes in right on the surface. So when the hip joint dislocates, that blood supply doesn't go with the dislocation. So the head of the femur um, uh, can develop avascular necrosis. So we want to get this hip joint, this dislocated hip back into place. Otherwise, the risk is developing avascular necrosis of the head of the femur. And as you can see on the bottom image there, it leads to bone death and in a very irregular um, uh, femoral head. And of course, that's not going to work as well anymore. The person's always going to have a limp, and that's going to lead to osteoarthritis of the joint as well. Okay? So we really try to get dislocations back into place as quickly as possible. Okay? Because remember, the ligaments are being stretched, the blood supply might be affected, and all the nerves around the joint are being stretched. Okay, so the sooner we get a dislocation in, the better. Okay, so infection of bones, osteomyelitis. So I mentioned before that bones are extremely prone to infection when a compound fracture has occurred. So a bone that's fractured and gone through the skin and is now exposed to the environment has a high risk of developing osteomyelitis. So bacteria can attach to all those little trabecular areas and within the bone marrow and set up osteomyelitis. Okay. If osteomyelitis were to develop in a bone, which is really unfortunate because it's hard to treat, and patients typically need intravenous antibiotics for at least 4 to 6 weeks to try and get rid of the bacteria. Okay? So really what we try to do is prevent the development of osteomyelitis when there's a compound fracture. And how do we do that? Well, we flush out the wound as much as possible. Copious amounts of normal saline and water just to flush it out. And often we send them to an orthopedic surgeon for the orthopedic surgeon to open the area and to flush it out even more and remove any bits of soil or rocks or anything else that's in the wound. Okay. So osteomyelitis can lead to what's called chronic osteomyelitis, meaning the infection just can't be cleared and they're left with chronic festering bone infection. And that can lead to ulcers on the skin where the infection is tracking from the bone and getting up to the skin and chronically draining. And of course it leads to chronic inflammation. Okay. So typically, how are you going to get osteomyelitis? For the most part, it's from an open or a compound fracture. Now, is there a risk every time someone has orthopedic surgery that they could potentially infect a bone with the orthopedic surgery? Yes, it's possible. Unlikely because those procedures are done sterilely. And lastly, but a much less common way of getting osteomyelitis is somehow you got some bacteria in your bloodstream and it's spread to the bone and it's set up an infection within the bone. Okay, but by far the most common way is an open fracture. Okay, and so here's an image of osteomyelitis. So you can see how hard it would be to clear all that bacteria that's formed in the trabecular meshwork of bone. Just even with IV antibiotics for 4 to 6 weeks, it can still be very hard to clear. And as I mentioned, open fracture, #1 way of getting osteomyelitis, but it is possible to also get it through the bloodstream where the bacteria has made its way into the bone and set up infection that way. So it's not always from a fracture. It's just the most common way of developing it. Okay. And the treatment for osteomyelitis, as I mentioned, IV antibiotics and also orthopedic surgery to debride, to remove all the tissue that's infected to try and clear the infection. Okay. Okay, so when we talk about osteomyelitis, well, acute osteomyelitis usually follows a fracture. Could it spread through the blood? Yes, it's possible, just a less likely mechanism. And it's going to give you symptoms of any bacterial infection. So fever, sweats, chills, nausea, malaise, and of course you're going to have increasing and persistent bone pain that's just not going to settle because you have bacteria growing at the site, right? There's also going to be more swelling of the tissue because of the inflammation and more tenderness, more warmth. So that's acute osteomyelitis. and that typically is within a month. Okay, so it's not like you develop osteomyelitis the day of a compound fracture. It takes a bit of time for the bacteria to set up an infection within the bone. Okay, and sometimes the bone can appear normal, except for say the fracture. The rest of the bone looks fine because the bacteria hasn't destroyed the bone yet. But as time goes on, x-rays will start to show that there's definitely destruction of bone by bacteria. Okay? Chronic osteomyelitis is where it's just persisting for months and months and months and years. And you just are unable to clear the infection. So you have chronic bone pain, chronic swelling at the area, tenderness, and there's systemic inflammation that's become chronic. And finally, the infection can make its way to the skin, and which is called a fistula. So a fistula is basically a connection from one tissue to another, so a channel, and it can drain pus and form ulcers. Okay, and definitely in chronic osteomyelitis, the x-ray looks abnormal because the bone is being destroyed. Okay, so this slide is just showing you common fracture areas. So a hip fracture, very common in older patients with osteoporosis. So if I think of a hip fracture, it's typically a patient over the age of 65 or 70, often a female because of osteoporosis, and they've had a fall at home or they've slipped outside on the ice. And they come in with hip pain, and their leg is typically shortened on that side. Okay? And that needs repair. They won't be able to weight bear until the hip is repaired. So we try to repair them quickly so we can get them back on their feet and try to avoid complications of lying in bed, such as decubitus ulcers, DVTs, pneumonia. Okay, so hip fractures are repaired soon, typically within a day. Wrist fractures are very common with osteoporosis, but they can happen without osteoporosis if the force is high enough. Okay, and the most common one is what's called a Colles fracture. Okay, vertebral fractures are very common, again with osteoporosis, and it's usually from a fall onto your bottom, and the force goes up the spine, and it compresses one or more vertebra, and you're left with compression fractures permanently. A femur fracture, pretty tough bone to fracture, so it requires high force, such as falling from a significant height, or a car accident, or a motorcycle accident. Any of those can lead to a femur fracture. Ankle and foot fractures are very common with inversion injuries. So where you slip off the sidewalk and you invert your ankle, and instead of a ligament tearing off, the bone fractures. Okay, so all of these are very common sites of fractures. Okay, so let's just look at some of these. So at the top left, there's a mid-shaft femur fracture. Okay, that's going to need surgery, typically with a rod into the bone on each side to stabilize it, or sometimes they'll put a plate on it. Once they put the bones into the correct position, they've reduced the bone. They'll put a plate with screws to mobilize the femur fracture. Okay. Bottom left is just a metatarsal fracture. So it's a fifth metatarsal fracture there. Relatively minor fracture. We usually just put those in a cast or an air boot cast, and they usually heal in 4 to 6 weeks. And the patient can typically walk on that type of fracture. An ankle fracture, so this one's showing a fracture of the fibula, which is the thinner of the two bones. You can see a line through the fibula, and also at the distal fibula, the distal tibia, you can see a fracture there, right at the ankle joint. That's going to be an unstable fracture. So both sides are broken, so the joint is going to be loose. That's going to require surgery to stabilize that type of fracture. Okay. A Colles fracture at the wrist, at the top right there. So you can see that on the side view of the wrist that it's not well aligned. Part of the distal radius has fallen off the back. So that's going to need to be reduced, and often it needs surgery to keep the bones aligned. Okay, so that's a Colles fracture. And finally, a compression fracture of the vertebral column. You can see that one of the lumbar vertebrae is compressed. So we call those vertebral compression fractures. They're very painful, and they just stay permanently like that. Okay, it's not like the bone grows back and makes a perfect vertebra again. It just stays compressed. Okay, and here's an image of a right hip fracture. Well, left when you're looking at it, but it's actually a right hip fracture. Again, very common in falls in the elderly with osteoporosis, which is not an uncommon event in the winter, right? So hip fractures are very common in the winter because of slippery conditions. And typically this will need surgery, whether pins or screws to immobilize the fracture site and to make it strong so the patient can begin weight bearing again. Okay, so it's all about getting the patient up as soon as possible after it's been repaired to prevent the complications that can result in more and more immobility. And unfortunately, some patients die of hip fractures, not from the fracture, but from the complications of a fracture. The bed ulcers, the DVTs, the pneumonia. Okay, so these are repaired as soon as possible. Okay, so let's look at some shoulder injuries. So at the top right image, you can see a humerus fracture. So the head of the humerus has fractured off the shaft of the humerus. Believe it or not, those heal really well, often just in a sling. They rarely need pins and plates, so they tend to heal quite well. Bottom right, anterior dislocation of the shoulder. So when the shoulder joint or the humerus comes out of the joint, it typically displaces anteriorly about 95% of the time. Sometimes it goes backwards, and that's a posterior dislocation. That is uncommon. Okay, so an anterior dislocation of the shoulder, and you can see it in this image where the head of the humerus is no longer in the glenohumeral fossa. And with traction in certain maneuvers, we can get that head of the humerus back into joint. And as I mentioned, often that requires sedation and IV opioids to control the pain while we're doing it. Okay. Top left, rotator cuff injuries. So around the shoulder joint, we have a set of muscles and tendons, and we call the whole group the rotator cuff. Okay, and they're very prone to injuries. Okay, because I mentioned that the shoulder joint is a very mobile joint, and because it's so mobile, it comes at the cost of being a bit unstable. So people often develop rotator cuff tendinitis. Okay, so you're getting a front view of the shoulder joint there and a back view of the muscles and the tendons of the rotator cuff muscles. Okay. Okay, I won't spend too much time on this slide because I've mentioned it as we've gone along. So the shoulder joint, very complex joint. It's still a ball and socket type joint, but it is really prone to injuries because it's so mobile. Okay, so it can fracture, the head of the humerus can dislocate, all because we have such a fantastically mobile shoulder joint. Okay. Now, the muscles around the shoulder joint that allows you to move it in all its directions are called the rotator cuff. And of course, muscles have tendons that attach these muscles to bones. And when you injure that muscle tendon group around the shoulder joint, we call it rotator cuff syndrome. Okay, and there's multiple muscles that are part of the rotator cuff, and depending on which muscle you've injured, we might call it a bit more specifically, but they're all part of the rotator cuff. Okay, so rotator cuff syndrome is the inflammation of the muscle and the tendons surrounding the shoulder joint. Clavicle fractures are very common fractures. They typically heal very well. They're very, very common in children, but adults can easily get them as well. And for the most part, they heal fantastically. Okay, so when we're talking about the shoulder joint, we're talking about the glenohumeral joint. Okay, and by far, it's the most common place for a joint dislocation, where the ball comes out of the joint. It can happen in the hip joint, but far less commonly. Okay, I mentioned it can happen in the knee, where the whole knee dislocates. That takes a lot of force. And I also mentioned it with the kneecap, where the patella can dislocate. That's pretty minor. It's really painful and uncomfortable, but we just put it back into place. Okay, but the shoulder is number one in terms of dislocations. Okay, so this is showing you the rotator cuff, which, as I mentioned, is a group of muscles that surround the shoulder joint, and they stabilize the humeral head into the glenoid fossa, right? And that's their purpose. And those muscles allow for all kinds of movements of the very mobile shoulder joint. And they're also prone to a lot of injuries. So as I mentioned before, if you go and decide to paint your entire house one weekend, and you're working a lot over your head and you're brushing back and forth for hours per day, there's a good chance you might develop rotator cuff syndrome, where you've worked those muscles and the tendons that the muscles attach to so hard that you have rotator cuff tendinitis. Okay, so it's usually from repetitive motions of the shoulder joint that you get rotator cuff tendinitis, or you've had an injury. So you've fallen and dislocated your shoulder, and you've stretched the rotator cuff tendons, and now they're really irritated, and you have rotator cuff syndrome. Okay, and the problem with this is that after the injury, you can't move your shoulder very well. And you can see this in the image on the right, where that person is trying to abduct their arm, and they're unable to. And that's due to rotator cuff syndrome. So the muscle and tendon that's trying to lift the arm up over his head is unable to because of the injury to the muscle and tendon. Okay, so these patients need a lot of physiotherapy to mobilize that joint and make sure that it doesn't become what's called a frozen shoulder, where they just are unable to mobilize the shoulder joint any longer, And you can imagine how disabling that is, because now they're left with a shoulder joint that's not usable. They can't move it in all the directions that are required to, say, comb their hair, brush their teeth, feed themselves. So a rotator cuff syndrome that's become a frozen shoulder months and months later is a significant disability to the patient. So we really try and prevent that with physiotherapy. Okay, so let's look at the knee joint next. So we're not going to talk about fractures around the knee joint. We're going to look at more ligamentous injuries and also what's called the meniscus. So if you remember, the knee joint is where the femur and tibia articulate. They meet at the knee joint. And you have hyaline cartilage. So that's the articulating cartilage on the femur and the tibia. And around the hyaline cartilage, you have what are called meniscus or menisci. Okay, and those are fibrocartilage, and they act as shock absorbers for the constant pounding to the knee joint with walking, running, or whatever else. And that's why hip arthritis and knee arthritis is so common, because they're getting constant pounding from walking and running and everything else that we do. Okay, so knee injuries predispose patients to even have a higher risk of osteoarthritis. So if you have an internal knee injury, such as you've torn the meniscus or you've torn one of the internal ligaments that we'll talk about, well, that's going to increase your chance of developing osteoarthritis, okay, because you've damaged the internal part of the joint. Okay, so let's look at the anatomy a bit of the knee. So the two internal ligaments that are very powerful that I'm talking about, that stop the knee joint from going backwards or forwards against itself, are the anterior cruciate and the posterior cruciate ligament. Okay, so they are within the joint themselves, and they both attach the femur to the tibia, providing a lot of anterior and posterior stability. The outer ligaments, the medial collateral and the lateral collateral ligament, are on the outside of the joint. Okay, so if you tear one of those ligaments, you're not as prone to osteoarthritis, because those are an outer joint ligament, okay, compared to injuring the ACL or the PCL or one of the meniscus. Okay, very limited blood supply to within the joint, so they just won't heal very well. Okay. And remember, the meniscus is not the hyaline cartilage that articulates. The meniscus are these rings of fibrocartilage within the knee joint that act as shock absorbers. Okay, so let's look at an anterior cruciate ligament tear. So this is a pretty common injury where one of the internal ligaments of the knee has torn off. And what can do this? Well, a twisting of the knee or some kind of tremendous force to the knee, such as downhill skiing with a fall, where the anterior cruciate just didn't have enough force to stay together, and it tore off. Okay, now you can have a partial tear of your ACL or a complete tear of your ACL. If you have a complete tear of one of your cruciate ligaments, well, that's going to make your knee joint wobbly and loose and unstable, because those two ligaments were holding the femur to the tibia and stopping it from moving forward or backwards on itself. Okay, so a full tear of one of those ligaments will need surgery. In particular, the anterior cruciate ligament, which is more commonly torn, that's going to need surgery to either reattach it or to use a tendon from somewhere else in the body in replacement to repair that cruciate tear. Okay. Otherwise, the knee is left with chronic instability. Okay, so let's look at the anterior cruciate ligament in a bit more detail. I mentioned it's the most common internal knee ligament to be torn off and creates a lot of instability of the knee. So when patients are walking, they can feel that their knee is clunking. They don't feel confident on their knee. It might give out on them because it's unstable. And often with the ACL tear, because of the force involved, there's usually a meniscal injury as well. That fibrocartilage that goes around as a ring of the joint has been torn as well. Okay, so initially it can be treated with a knee brace, but typically an ACL tear needs a graft, right? So it can be an autologous graft, which is taken from the patient, another ligament or tendon taken from the patient, or a graft taken from a cadaver, okay, to repair the anterior cruciate or even replace the anterior cruciate ligament. Okay, what's Lachman's test? Well, if you don't have an intact anterior cruciate ligament, when we grab the upper calf and pull it forward, it shouldn't move usually. If the anterior cruciate ligament is completely intact, it's not going to let us move the joint out. Okay? If your ACL is torn, I can move the tibial part of the knee joint forward. So that's going to be called a positive anterior drawer test. Okay, so that's the Lachman's test, where we'll grab the thigh, we'll grab the upper calf, and we'll pull forward on the upper calf. And if there's give, meaning if I can feel the knee joint move forward, that's a positive Lachman's test, and that's typical for an anterior cruciate tear. Okay, so there's a nice image of the meniscus, and you can certainly see how there's circular fibrocartilage of the knee joint, and they provide the shock absorbing ability of the knee so that the hyaline cartilage isn't damaged, right? So you have the hyaline cartilage on the femur and the tibia, but you have these meniscus that are taking the impact, and these can be easily torn, right? So if you rotate, if you have a skiing injury and your knee twists, well, you can shear off some of the meniscus and it tears off. And when that happens, either the meniscus has to be surgically repaired, or they'll just cut off the loose part of the meniscus. Okay, so you can imagine that this has caused internal damage to the knee joint, and these people are prone to wearing out their hyaline cartilage because they don't have that shock absorber ability anymore, and leading to osteoarthritis. Okay, so as I mentioned, sure, you can wear a knee brace for stability, but really arthroscopy, where they put a camera, they puncture the knee joint with a camera and a little pair of scissors, and they can clip off a portion of the meniscus with the arthroscopy.